For the next 20 minutes, I'll be talking about non-clotting factor options, the global perspectives. Those are my disclosure. Well, what is the ideal product for the hemophilia treatment? The ideal product is the one that should be able to overcome the limitations of the coagulation factors concentrates and have the following characteristics. Longer half-life, facility to administer, they are non-immunogenic, they offer stable hemostatic protection, they are effective for patients with and without inhibitor, and have affordable cost. As we know, extended half-life factors, there remains still the need for IV access and the possibility of inhibitor development. Gene therapy is not for everyone. Patients with inhibitor, liver disease, or positive adeno-associated viral antibody cannot be submitted to gene therapy. So today, we are living a new era for hemophilia treatment, where alternative therapy are being developed that is not based on factor replacement. They have two basic mechanisms. They can mimic coagulation factors, or they can rebalance the hemostasis systems by acting as mutants or by interfering with natural anticoagulant. Three drugs are mostly discussed today in literature and are far advanced in clinical trials. They include emicizumab, fitusiran, concizumab. And so those are the three drugs that I will focus on and discuss the global perspectives. Emicizumab is a recombinant humanized monoclonal bispecific antibody that restores the cofactor activity of factor VIII. It is administered prophylactically, subcutaneously, and weekly, and probably monthly. It is not expected to induce factor VIII inhibitor, since it's a different molecule. It may be used in persons with hemophilia A with and without inhibitor, and clinical trials have shown that emicizumab reduces the annual bleeding rate. Recently, it was approved by the FDA for prophylaxis in adult and pediatric persons with hemophilia A with inhibitor, also approved recently too by EMA. Nevertheless, there were 5 patients that presented severe adverse event, 2 thromboembolic event, and 3 thrombotic microangiopathy when they were submitted simultaneously to emicizumab prophylaxis and multiple infusion of APCC for breaking through bleeding. As a result, there was made changes in the protocol that recommending to reduce the dose of APCC or even switching to recombinant activator factor 7. And since then, there has been no report of thrombotic event in clinical trials. Fitusiran. Fitusiran is a RNA therapy that targets antithrombin messenger RNA, thus suppressing the synthesis of antithrombin in the liver. It may be used prophylactically, subcutaneously, weekly or monthly in person with hemophilia A or B with and without inhibitor. A thrombotic event occurred in a person with hemophilia A without inhibitor that needed associate fitusiran for prophylaxis with factor VIII replacement for an intracranial event that was misjudged to be a bleed. As a result, Amline company, pharmaceutical company, she suspended the fitusiran dosing in clinical trials in September 2017. In December 2017, the FDA lifted the clinical hold with the recommendation of reducing the dose of APCC and bypass agents and replacement therapy in case of bleeding. Concizumab. Concizumab is a monoclonal humanized antibody specific for the second kinase of the TFPI, the binding site of activator factor 10. It may be used prophylactically, subcutaneously, weekly, or monthly in hemophilia A and B with or without inhibitor. Up to now, no thrombotic event has been reported. So we have seen that these three drugs have been evaluated in a prophylaxis setting, and they seem to fulfill the goals for a more convenient and effective prophylactic therapy. They have longer half-life, they are easy to administer, so they will, of course, increase the compliance to prophylaxis. They also are effective for patients with and without inhibitor, and they are non-immunogenic. But it is for the persons with inhibitor that this new drug will be the greatest benefit and have the greatest impact. They will increase immensely the therapy options, especially today so scarcely, and they will allow effective prophylactic therapy. We know that the response to bypass agents are very imprecise. And as a result, we'll expect these patients to improve their joint function. Nevertheless, there remains critical issues concerning especially safety, efficacy, especially outside of clinical trials, and of course, concerning cost. Regarding safety, there are many unresolved and important questions. Is there a risk for thromboembolic event? What happens when rescue with bypass agents or coagulation factors are made necessary? What are the risks for children and newborns? How will these new drugs interfere with hemostasis assays? And how will the immune system behave towards these products? Hemostasis, we all know, it's a balance between procoagulant and anticoagulant forces. These drugs, they promote the disruption of the system by trying to compensate for the procoagulant deficiency, and this can induce thrombosis. This question will better be answered with the observations outside of clinical trial in real world. In relation to thrombosis, when a rescue with bypass agent or replacement therapy is necessary, concerning emicizumab, we have seen that reducing the APCC, the dose of the APCC, and or switching to activator recombinant factor 7, these actions may have shown to reduce the risk. However, for the risk of thrombosis with the simultaneous use of fitusiran and factor 8 replacement, this is it will be more complicated for us to manage. Low doses of antithrombin and or even normal level of factor 8 can be thrombogenic. So will reducing the dose of coagulation factor replacement be enough? Is there a role for antithrombin concentrate? How to reach the ideal balance? Simultaneous use of non-clotting factor and factor therapy will definitely require more further studies. In relation to children, the risk for children. Today, the main concern with replacement of factor concentrate is the development of inhibitor. Inhibitor is more common in children. The fact of this drug being non-immunogenic, easy to administer, and prevent bleeding make them the ideal treatment in this age group. However, we know that hemostasis is incomplete at birth and matures throughout infancy, when exactly they initiate prophylaxis. As we see in this table, children, they have lower level of coagulation factor, anticoagulant factors, and even some proteins of the fibrinolysis system when comparing to children. So the disruption of this weak balance can lead to more easily to bleeding or thrombosis. Interference with hemostasis assays. All the three drugs increase degeneration of thrombin. But suppose at some point we need to evaluate the inhibitor titer or the level of factor 8 or factor 9. Will that be possible? Well, emicizumab, for instance, have been shown to affect the hemostasis assays. For instance, it corrects the APTT, it creates a false negative result for the factor 8 inhibitors and based on APTT beta assay, and so on. For the other two drugs, we don't know yet much. But one thing we can expect, that these drugs will change the current hemostasis laboratory routine. In relation to the immune system, these drugs are susceptible for the arising of anti-drugs antibodies, and this may compromise efficacy. 4 individuals were suspected to develop anti-drugs antibodies in clinical trials without compromising pharmacokinetics and pharmacodynamics. But this data is small, and it's early for us to draw a conclusion. Regarding efficacy, the great question is, are these drugs effective as sole therapy in the treatment of acute hemorrhage, surgeries, and trauma? Well, recently, in ASH 2017, Rebecca Cruz, she shows some data on some results on experience with surgeries in patients with hemophilia A and inhibitor. 22 patients were submitted to 29 minor procedures. 19 of them did not receive prophylaxis bypass agents. 14 did not bleed. 5 did bleed, but only 2 needed treatment. This is a small number. We need more data. And it seems that a clinical trial is going on to evaluate the use of emicizumab in surgery. Another important issue about these drugs is cost. In the last few years, there's a great concern about cost in hemophilia care. Numerous reports have been published discussing this subject. The economic burden of hemophilia treatment is mainly the replacement with factor concentrates. These new drugs will further increase the pressure on health care budgets, regardless of the environment, and this will be a limiting factor. 75% of people with hemophilia live in the developing countries. They are unable to have access to conventional coagulation factor concentrates in adequate quantities. These countries have many challenges. Without specific strategies and programs, the novel therapies will be out of their reach. However, the increase in the development of new drugs will increase the options of treatment. More options are available. This can bring hope that price may reduce, and this will have great benefit for these individuals in developing countries. For the developed countries, the decision about the financial outlay and the patient's need will require discussions discussions with patients, clinicians, healthcare payers, and industries. Another tool that may help you is pharmacoeconomic. This method is useful to evaluate the various medical options, especially with the forthcoming more expensive ones. However, poorly conducted economic evaluation may mislead both clinicians, leading to inadequate treatment choices, and those responsible for the payments. To finish, I would like to sum up saying some few words. These products will provide effective options for prophylaxis, and also it will be possible to individualize treatment. Therefore, it will improve outcomes and cost effectiveness. This product will bring good perspectives for the hemophilia treatment, but particularly for the patients with hemophilia with inhibitor. However, the overload of choice will require more discipline to achieve and assure best clinical benefit. More options available may reduce the price and benefit the patient with hemophilia in developing countries. Of course, there are some concerns of the use of these drugs, but the enthusiasm for them prevails. Further results of the clinical trial will provide important information that will help us in decisions. Thank you very much for the attention.